Sounds good.
Well, good day, everyone. My name is Julie Jensen, and I'm a director in Pfizer's Global Health and Social Impact team. I'm also the chair of PQMD. And today I have the honor of welcoming you all to PQMD's third event in our series of regional roundtable discussions. As many of you know, we will happily be back together in person next year for our Global Health Series Forum. And we'll be in Paris, hosted by Tulip. And though we've missed being together, this is clearly an important new effort from the PQMD team. Over the last few weeks, we've highlighted the rich interests and experience of our PQMD family at a regional level and generated new connections and a fresh appreciation for not only the complexity of the work that we do, but the compassion and the competence of our global partners. And we're so inspired by the work of all of our PQMD members around the world. For those of you who might be new to PQMD, we are a global alliance of international NGOs and leading healthcare companies, and we're committed to advancing the role of product donations worldwide. Founded in 1999, our work is guided by 5 pillars: humanitarian assistance, health system strengthening, disaster response and preparedness, guidelines, and knowledge management. PQMD relies on the strength of our coalition and the work of our members and the work that they do every day to inform our ongoing programming. We also host a community of practice, and we invite you to join us for upcoming events, utilize our product donation guidelines, and our signature practical tools. We will drop some helpful links in the chat box along the way so that you can continue to engage with PQMD. You can also find links to our previous sessions on the migration crisis in Latin and Central America, and health system strengthening challenges in the Middle East. And we encourage you to view these recordings on PQMD's website. So today, I am so excited that our focus is on the African continent. We have a magnificent panel of diverse public health professionals, and together they have over 100 years of global development experience. They have worked together with our moderator, Mike Hogan, international medical teams, to develop an agenda for today's session. We'll cover the COVID-19 pandemic realities and responses, vaccine equity, opportunities for sustainable growth, innovation in programming, and the shifting scene of leadership and community experience in the pursuit of better global health outcomes. So now it's time to get started. Whether this is your first PQMD event or you're a seasoned pro, we want you to know that this is a place for you to network. So welcome again, and please put your name in the chat box. We love to know who's on the line and which organizations you're representing. And so quickly, we do request that all participants remain muted throughout the main presentation. Feel free to add to the discussion in the chat box, add your questions and comments, and we'll see if we're able to get to them with our speakers. And lastly, we are recording the session and we'll post it on the website. And so now I have the honor of introducing, and we have the honor of hearing from Stephen Cahill, the Chief of Humanitarian Logistics Services and Supply Chain Division at the World Food Programme. The network Stephen leads plays a vital role in pre-positioning and rapid dispatch of relief items in emergencies on behalf of the humanitarian community. Stephen has an extensive global logistics experience in both the public and private sector and multinational organizations, in roles ranging from director of the company to director at a national level. Throughout each role, he has chosen to leverage the power of partnership to ensure supply chain services are intact and functioning to serve people in need wherever the disaster and emergency hits. Prior to his current role, Stephen was WFP's Chief of Logistics, and while covering in this role, he played a central role in designing, implementing, and overseeing a global platform of common logistics services in response to the global COVID-19 pandemic, supporting over 400 organizations. His experience draws from his professional engagement in a variety of emergencies, and most recently, in calling in today from the Deputy Emergency Coordinator of the Ukraine response. But also he served in Mozambique in 2019, Sierra Leone during the West Africa Ebola outbreak in 2014 to 15, and the Typhoon Haiyan in response in the Philippines. Stephen, we look forward to hearing from you today, and we are so grateful for you making time in your schedule to help us with this conversation. So I'd love to turn it over to you.
Great, thanks, Julie, and thank you very much for that introduction. So yes, I'm calling in for Lviv, so excuse me if the connection is not great. There's the odd air siren to give a bit more drama to our day-to-day, but hopefully we'll get through the next 15 minutes without that. There's a couple of things that I'd like to talk about, a little bit about WFP in the food context, talk quite a bit about what WFP does outside food, and I'd like to link that back into the COVID, into the pandemic, and how we handled that and how it affected our operations, and perhaps link that a little bit into what people might know about what we foresee and happening with the Ukraine crisis. So on that basis, to talk a little bit about WFP very quickly, it's an organization of 20,000 staff members. 90% of those are based in the field. We operate in 82 countries around the world. We have a budget which is completely voluntary funded of about $8.5 billion. And last year we fed about 120 million people. I've been working for the organization for 16 years now. And of course, a lot of our staff members, one is that are from the private sector themselves, like myself. I joined when I was 40, so now you can calculate very quickly what age I am. I think we feel very comfortable with the private sector. So it's a great opportunity for me to talk. When I looked through the list of your members, you see there's such a strong private sector engagement, and I'll try and talk through that a little bit as well. Because certainly as a humanitarian, as WFP, we see the interrelationship with the private sector as being critical, especially when we talk about pandemics or health responses. But just to give you a little bit of an example of that, I think the first time that I got involved in a health response was in Ebola 2014, deployed to Sierra Leone, had no experience in the health sector, and no experience in a widespread epidemic at that stage. And of course, it was a very steep learning curve for the organization and for myself. I think that we did okay in it, but I think coming out of it, we knew that we didn't do as well as we should have. We were asked to take on a huge role within the health sector as well, supporting especially WHO, but others as well, the ministries of health, with everything from setting up warehouses, cold chain, commodity management, all of those things which we know on the food side, but that's very different to a health side. And of course, what we realized as well is that we didn't have the ability to be able to ensure that our staff, one, were able to handle those health products very well, and secondly, how to deal in those environments. However, we did learn one very big lesson, is that when the private sector pulls out because of a health crisis, the burden that falls on the humanitarian sector increases abnormally. We saw that when one is that we couldn't get our staff in and out of those 3 West African countries because the airline stopped, bar one, I think, which was Brussels Airlines, which was then supported by the Belgian government. We saw that shipping lines had stopped moving, borders closed down, which means that not only do we have difficulty moving humanitarian cargo in and out of those countries, we also had a lot of difficulty moving our own staff and other humanitarian staff in and out of those. And that kind of brings me around to about WFP is known, of course, the F bit is on the food, but we do a huge amount which is non-food items, right, which we do support to partners. So to give you some example in numbers, about 1/8 of our budget goes into actually supporting third parties, right? So that means everything from the humanitarian air service that we run through 23 countries. I think last year we carried around 313,000 passengers, and we only do that because the private sector is not in those countries such as South Sudan, Yemen, Central African Republic, or we don't have a quality of service where we can ensure the safe passage of those humanitarians. Then, of course, we do things like the logistics cluster in the emergencies and Ukraine across 13 countries where we're supporting partners as well. So this has expanded over time and continues to expand. And today, in a kind of value terms, it's worth about $1 billion, all of which is plowed back into those organizations. So we make sure that we're able to provide the warehouses, the trucks, the cold chain facilities, and of course, the air operations when they're needed. But of course, when I go back to West Africa and the Ebola outbreak is that when we see that the private sector retracts, is that one of the things that we've been trying to do since then was one is to prepare for the next pandemic, which we did not expect to happen with COVID-19 in 2020. But we had been preparing it with WHO. So I think we can say that we had learned quite a lot from that, right? So I think we basically asked ourselves a lot of the questions which then came through when we saw in COVID. I think we got two things wrong, right? I think was one, how quickly the pandemic spread, and we saw that how dramatically that happened. The second point was that we had based all our thoughts on and preparedness on that it would hit those countries with weak health systems first. And of course, what we saw was the exact opposite. We saw that the first country in the developing world that was hit was actually where WFP's headquarters were, was Italy. And of course, for an organization whose headquarters is there, whose main surge capacity is there, that of course had a major impact on what we did. So even with that preparedness, there were two major parts that we got wrong. What we got right, and what I think on an optimistic side, which we were very happy with, is that countries did not close down. So those borders, countries did not isolate themselves, and those borders remained open. And that's important for WFP as we move about 4 million tons across the world every year to ensure that we can get food to those, and not only food, but other commodities for those most in need. And that was very important for us. It also showed us that we had the ability as an organization to decentralize. So we had the systems in place that allowed Italy, which our headquarters essentially closed down, to ensure that we continue remotely from home and to do so. But not only did we have to work from home, we had to set up a whole system to step in for the private sector. Because as we all saw, the first thing that happened was airlines stopped moving. And when airlines stopped moving, it means that 40% of the air cargo in the world, which goes in the underbelly of aircraft, was no longer there. So WFP had to step up in a major way. And we did that, but that cost the organization, and I can say with my own head of hair, a lot of gray hair on that side as well. We moved 150,000 cubic meters around the world to 172 countries for 400 partners. And if you consider WFP only has presentation in 82 of those countries, we're moving cargo to where we didn't even have representation. We were chartering those aircraft ourselves, or we were also just subchartering space on them. But that was a huge, heavy lift for the organization. And again, when I go back to the private sector, I don't think that the humanitarians really needed to step into that. I think the engagement that we need to do now as we go forward with this is, how do we build up that relationship with the private sector to allow them to understand, not only in pandemics, but any other shock that we have, to ensure that the private sector stays in place. And if we bring that round to Ukraine today, that means how do we ensure that the humanitarian intervention is not so heavy because the private sector stays in place? And that's important for us today as we're talking in Ukraine, where we have like something 11 million people either who've left the country or have been displaced in the country. And if you consider our most recent work in a similar environment is Syria. It took Syria 10 years to get to 10 million IDPs or refugees. It took Ukraine 1 month. And that is a huge pressure that it puts on the humanitarians, but also not only because they have to step in, but also to the shock that the private sector is currently undergoing. And this rounds back now to a little bit is how we are ensuring as an organization that we're trying to support the private sector here through the warehouses that we're using, the transporters we're using, and of course the food procurement that we're trying to do in country as much as we can instead of importing it. And that's very important for us as we go forward, right? And it's not only the food, but it's also all the other commodities that go along with this response. So that's the health, that's the shelter, and of course, then we need to start thinking about the rebuild as well. And really, my last message as well is this, to reach out again to the private sector, is how can we teach the private sector to stay in place in places like Ukraine, to minimize the economic impact, to minimize the humanitarian burden, and thirdly, for the private sector, is how do you secure those investments that they have been making? And that could be in countries like Ukraine, it could be Syria, it could be Yemen, as especially multinationals start to develop and go into more, I would say, countries that are susceptible to shock. And I think that as humanitarians, we can teach the private sector about how to absorb these shocks, be those natural emergencies or sudden set emergencies, or be those conflicts, because that's what we do in our day-to-day. Because we know that if this sector goes out, the burden again goes on the humanitarian. If the burden is on the humanitarian, that has a very financial implication. And that's what we want to make sure that we avoid. I'll stop there. Julie, back to you.
Oh, thank you, Stephen. And again, thank you so much for the background and the work that you're doing. I do have just one or two follow-up questions since you're in Ukraine, talking about the private sector. Are there vacuums that you're seeing specifically in the health sector in Ukraine right now that you think private sector could help fill?
So what I am seeing in the private in Ukraine itself, that yes, you can imagine that the civilian casualties are considerable. So people have lost their homes, people are displaced, and I think we're just seeing the start of it. Our concern as well is that the generosity being shown across the world when we have these influx of goodwill, not only financially, but also people giving goods, is absolutely fantastic. And those countries welcoming those 4 million refugees that have currently left Ukraine. But Ukraine needs to be rebuilt, irrespective of how long this conflict goes on for. There will be a requirement for people to go back, and people always want to go home. I don't think we've fully seen what the impact is on the health sector yet, but I know, for example, of the work that we're doing and the relationship we have with the ministries of health, that they are in desperate need of, because there are so many more casualties. We see today, for example, the morgues are full, and you can imagine then, of course, the outlay for the impact on the health sector. As an organization whose primarily response is in food, what we have seen, though, is that 50% of the grains we buy in the world are from Ukraine. And currently, Ukraine is unable to export because all the Black Sea ports are inaccessible for whatever reason. Mm-hmm. And that, of course, has shot up the price of food, which means that pushes a huge number of people into poverty. We saw with the pandemic, about 100 million people extra moved. From 180 million people to 270 million people moved into poverty. We have currently today 44 million people who are on the edge of starvation, and we don't use that term lightly. We use starvation as in famine. And that, again, of course, is exacerbated by high prices now, which is not only for commodities, but fuel. We have COVID, and of course, on top of that, we have climate change. So I always try and stop myself is that things never look good, right? But this is a time when I think the world really needs to come together.
And I guess on that transition to the global impact here, where is WFP looking at kind of the hot spots for food shortages, famine, like you said, hunger? Are there certain areas of the world that you're kind of pre-positioning?
So our main focus, of course, is in certain parts of Africa, and that moves around quite a lot. East Africa is now going through a serious drought that's covering parts of Kenya, Ethiopia, Somalia are the main countries, and that'll go further along. There's an impact that on two things, and one is the current conflict in Ethiopia, which gives a very difficult access to certain parts in the north. And of course, there is a link to fundamentalism, as we have a band of radicalization along that Somali corridor all the way down to Mozambique. And of course, the Sahel in Northern Africa will be impacted, one, by a poor rainy season, and secondly, is they are very reliant on specifically Ukrainian wheat. And there are major concerns today.
Thank you. And can I ask you one last question as we transition now into COVID? What are the biggest lessons in pandemic preparedness that you've seen in Africa, specifically related to COVID-19?
So what I've seen from an outsider, one is, I think that it has been seen, we're still very close to it, right? So one is that COVID seems to have left everyone's mind now in my world. And when I look at the response in Africa completely, I think this can be helpful in some ways, because I think there's a huge hesitancy on the continent towards COVID. However, it brought up a huge sense of inequity. And that inequity started off as a COVID vaccine inequity, and that today is actually a health inequity, and that moves into a general inequity. And I think that Africa now must be concerned that this whole focus has moved suddenly to the West, to Ukraine. And again, I feel that Africa is forgotten. And I think that is a terrible travesty for the world to consider today. So that focus needs to stay on those 1 billion people who are in Africa, not the 44 million people who are in Ukraine. There needs to be that still link, and we cannot forget the continent.
Thank you. Well, we will, first of all, yes, we appreciate you calling in today. Feel free to stay on as long as you can. But again, thank you for the work you and your organization are doing. And we will now shift the conversation to Africa and COVID-19. So thank you. So with that, I would like to welcome Mike Hogan. Mike is the Vice President of Marketing and Development for Medical Teams International, and he's going to serve as the moderator for our next panel. Mike comes to global health with a seasoned lens on human rights and international efforts to end human trafficking and modern-day slavery. He worked in development for International Justice Mission, IJM, for 11 years, playing an instrumental role in growing the organization from $18 million to $70 million in private income. Prior to his time at IGM, he earned his MBA at Santa Clara University. The last few years, Mike joined Habitat for Humanity in Portland, directed its development team, and overseen major gifts, annual giving, corporate foundations, digital marketing, and a capital campaign. Mike brings extensive strategic leadership skills and not-profit philanthropy experience to everything he does. Mike, welcome. I know you're a newer representative to PQMD, but we really appreciate you already stepping into a leadership role. So thank you so much, and I will turn it over to you for the panel.
Thank you, Julie, and thank you, Stephen. Your comments were incredibly powerful and insightful, and I thank you for reading my bio, but I am actually quite humbled by the amazing panel that we have today that is far more talented than my own background. Before we jump in, I just, as I was thinking about today's panel, I was reminded of one of my favorite quotes from Martin Luther King Jr. from all the way back to 1964. He shared in one of his speeches. It really boils down to this, that all life is interrelated. We are all caught in an inescapable network of mutuality, tied into a single garment of destiny. Whatever affects one directly affects all indirectly. I think that he had such insight about the power of globalization in the 60s, and that's far before the power of globalization has kind of been birthed to now. We are truly globally connected. We're having this conversation over Zoom that allows all of us to come together around the world from different time zones, different places to have this conversation today. That's unbelievable. And our world is truly interconnected. Even some of Stephen's comments show how the current crisis in Ukraine is having other impacts on other parts of the world, particularly in Africa. So COVID-19 was truly a unifier. It was something that was felt all around the world. And while the impacts of COVID-19 pandemic were felt globally, Africa experienced compounding challenges of inequality to vaccine access and pressure the pandemic asserted on an already stressed health system. Stephen made that point very clearly in his final comments. And we're seeing those effects still. Africa lags much of the world with just over 15% complete vaccination rates and 1% boosted rate. And the World Bank's biannual analysis of near-term regional macroeconomic outlook estimates that growth in Africa is down to 3.6% in 2022. That's down from 4% in 2021 as the region continues to deal with new COVID-19 variants, global inflation, supply chain disruptions, climate shocks, and all that is being compounded by the region's growth challenges that are rising from commodity prices as the conflict in Ukraine is happening and having direct effect on Africa. But despite these challenges, the public health leaders across the continent responded in unbelievable ways. And they are still responding with resilience, and they're leading many solutions that address challenges while they also laid the foundations for an expanded public health response to future health crises during the pandemic. African countries were leaders in executing best practices in responding to COVID-19, and they leveraged existing public health infrastructure and expertise to respond to crisis. They had expertise in responding to HIV/AIDS, Ebola, And they use that expertise to also manage drug supply chains and virus surveillance. Today, I'm incredibly excited for us to hear more stories of resiliency from our excellent panel today. Our panelists are amazing, and you could read their unbelievable bios online. You could go to PQMD.org and see their extensive background. But I'm going to introduce our panelists right now. First, we have Dr. Wantwoson Asifa. He is the Director of Global Health Programs and Development for Project Hope. We also have Abby Ayula. She is the Supply Chain Lead for product donations at Pfizer. And then we have Belinda Buhudu. She is the Associate Director with Lilly Global Health Partners with Eli Lilly. We have Dr. Lali Chani. She's the Country Director in Tanzania with IMA World Health. And finally, we have Maria Oshigobo, Deputy Director of Party Nigeria for USP. So in our opening round, we're going to do what's called opening round robin, where we hear from each of our panelists. So I know all of you have important stories and insights to share as to how Africans can lead and are in fact leading many solutions that address challenges from COVID-19. But our panel in Latin America started with this question. I thought it was excellent. And that was kind of to start with the end in mind. I would like us to take a step back and ask, what is one key takeaway each of you panelists want the audience to walk away with today? We're going to take 2 minutes per person. And pardon me if I kindly have to cut you off and move us on to the next person. No offense. So we're going to start with you, Abby, but what is one key takeaway you want the audience to walk away with today?
Thank you very much, Mike. I'm going to take it from your global interconnectivity. So we have learned from the COVID-19 pandemic that we're so connected, and it does not take time to have outbreaks spread across the world. So I think we need to proactively hone our health system strengthening strategies and develop specific, measurable, achievable, relevant, and time-bound goals whereby we can measure various levels of maturity on the various points that we need to develop, so that even if we're not our end game yet, when the situation arises, it becomes easier to adapt our plan to be able to mitigate the situation we find ourselves in at any point in time. Thank you.
Thank you, Abby. Maria, let's hear from you next. What is one key takeaway you want the audience to walk away with today?
Okay, thank you very much, Mike. I would like to add to what Abby has said, to mention that for a system to be resilient, we all need strong will and commitment. So African leaders and every key stakeholder in the working in Africa should show high level of commitment in terms of investing, in terms of willingness to commit to ensuring that emergencies are addressed promptly, so that Africans will not suffer the catastrophic effects and the full impact of emergencies when they occur. Thank you.
Thank you, Maria. Dr. Asifa, what is one thing you would like everyone to take away, walk away with today?
Yeah, thank you. For me, the world and the globally, we've learned a lot from the COVID-19 pandemic, and particularly when it comes to the way we design and implement development activities and initiatives globally, particularly in Africa. So I just want to share experience and observation, how we learn lessons from the
I think we're having a little connectivity issues with you, Dr. Asifa. We'll come back to you. Belinda, can we hear from you? What is one key takeaway you would like everyone to walk away with?
Sure, thank you. Thank you, Mike, and thank you, PQMD, for this opportunity. It's a pleasure to join you today. I'm going to borrow from an African proverb that says, if you want to go fast, go alone. But if you want to go far, go together. And there has been so many experiences during this pandemic, a pandemic that really opened up all the gaps in our healthcare system, but also showed us that there are so many things in place already that we can harvest from, that we can use. There is a new level of leadership that we're experiencing on the continent, I think. Whilst the problems are so big, with the right leadership and working together as partners, we can go so far. We really need to harness the power of partnerships. We can no longer look at each other and say, you're private sector, I'm not going to work with you, or this about the public sector. We all need to come together. The problems are too big. Even if I think of, the industry that I work in, we can't even look at our competitors anymore and say we can't work together on problems. There is so many problems. The pandemic has highlighted it. We're not building from zero, but only if we work together, only if we come together as partners, hold each other's hands, can we find solutions to the challenges that we face.
Thank you, Belinda. What a beautiful proverb. Dr. Asifa, I see that you are back online. If you would, if you have stability with your internet, if you want to jump in and answer that question. If not, we can move to Lolly. Can you share your perspective? Oh, there he is. Okay, Dr.
Sorry.
No problem. What is one?
Sorry. Yeah, I mean, at this end, my connection is not very stable, but let me quickly address that question. I was trying to say, we've learned a lot from the COVID-19 pandemic, and what I just want to share in terms of like an experience, how we've learned from the pandemic and post-pandemic, and how we sort of like, starting to redefine and rethink our development principles and development models.
Thank you, Dr. Asifa. And Lolly, we will end with you. What is one key takeaway you would like everyone to walk away with?
Thank you so much, Mike. I appreciate this opportunity to share my thoughts with this distinguished group of people. First of all, I would like to add to what Belinda was saying. I believe that collaboration and partnership is key. And when we talk about partnership, I think we have to keep in mind it's not just among the public entities, but private sector is very important part of this collaboration. Particularly if we think about also the faith-based sector is also one of the elements we should not forget. Because if we think about Africa, we know in some countries, faith-based facilities provide 50 to 70% of health service delivery, particularly in rural areas and reaching the most marginalized populations. So that's why I think when we talk about tackling such a complex issues, we need to use all venues and strengthen our partnerships and use existing platforms and systems to build on, because we have been successful in many fronts. And I think we should use those successful platforms and systems which are already there to tackle new challenges and new problems. For example, we know we have surveillance systems for malaria, and then we have cadre of people at the rural facilities and communities and urban facilities and communities who can be used also to deal with COVID-19. And yes, we need to provide some additional resources and training and guidance, but we do have to use existing platforms as much as possible, because when emergencies happen, we don't have luxury of building new systems and new structures. We have to use what's there. We have to use what worked before, and we have to work closely engaging public and private sector and faith-based organizations to work all together to tackle the complex problems.
Thank you, Lali. And that's a great concept, that there's a lot of infrastructure and expertise already in place. So we're going to move to the individual panelist questions. So I have questions for you. And Lali, you actually really set up well the question I have for you, Abby. So Abby, from your experience with Pfizer leading product donation efforts in Africa, how were some of the public health programs able to react and or manage their activities during the pandemic? So that's really tapping into what were some of the things that were already in place. So how were some of the public health programs able to react and manage their activities during the pandemic? And if you have specific examples and stories, that would be fantastic.
Thank you, Mike. At Pfizer, one of the programs that I oversee is the trachoma elimination program, which is part of the neglected tropical disease system elimination that is being run by the World Health Organization. At the onset of the pandemic, some guidelines were provided, decision-making processes, which allowed implementers, countries, NGOs to be able to do a risk-benefit analysis of executing some of their programs and their mass drug administrations in the various countries. So they had guidance on whether to go ahead or not, depending on the seriousness, the need, and the seriousness of the epidemic or the pandemic in that area. In addition, a number of precautionary measures were put in place, which people had to look at. Measures like what are the capacity building, what's capacity building do you need? What training do you need to give the staff under the circumstance? What were the virtual training that were being done? So a lot of virtual training systems were created. How could we amend the service delivery system? So do we have enough workforce to do a house-to-house drug administration rather than having people come together in a community? Are we able to schedule various timelines for various people? We had to engage various stakeholders in the various communities to be part of this. We had to have media communication systems in order to be able to manage the concerns of the communities in terms of what are the risks they think and how are we managing it. We had to manage rumors. We had to engage with media organizations, media platforms who would help with this communication. So there was a lot of oversights being given by various bodies locally, and feedbacks were collected. So based on some of these precautions for the workers, precautions for the communities. So there were various guidelines that were developed, which the implementers and the various entities were able to use in order to be able to continue to administer their programs in areas where they were deemed to be needed and very important at that point in time. Thank you.
Thank you, Abby. Let's jump to you, Lali. Africa has just over a 15% vaccination rate across the continent, but it is much lower in sub-Saharan Africa. From your experience, what are the key challenges hindering increase of COVID vaccination rates in sub-Saharan Africa?
Yes, as you mentioned, that vaccination rates are very low in Africa. And obviously, there is a great variance between the countries because we have some examples of countries like Botswana, Rwanda, Malawi, Mozambique, which have over 35% coverage rate. But if you look at, for example, in Tanzania, we have 6% of the total population vaccinated and close to 12% of the eligible population, which is people over 18 years of old, are vaccinated. And as we know, the issues, again, there's no cookie cut kind of approach here, and the challenges also vary from country to country. But if I can summarize some of the key challenges, I would say that they probably come in few categories. First would be inadequate storage capacity and supply chain challenges, particularly as we talk about countries' ability to store and distribute the and maintain the cold chain across the continuum of the cold chain. That's one of the key areas. And then reaching the last mile. We know that when we talk about vaccination rates in urban areas, it's much higher than when we talk about vaccination rates in rural communities. So that also shows that issue of equity and access to services still comes and becomes very visible when you look at the vaccination rates and how we are progressing on that. I think the big challenge of limited health workforce makes it's very challenging to deliver vaccination because in most countries there's no adequate surge capacity, and we know the vaccination campaigns require increased engagement of health workforce. And when I say that, it doesn't mean only people who work at health facilities, because we need to do also community mobilization, we need to engage people. So it means also the community-based health workers and others who are engaged in this process. And we also see there are some competing priorities because nobody eliminated the malaria and other diseases which key burden our health systems in Africa while we had COVID, right? So health care service providers still have to deal with those routine issues, and maternal and child health, malaria, HIV, TB, you name it. Like we have whole complex of issues that we still need to deal with. And recent polio outbreak in Malawi, which now requires Tanzania, for example, to conduct campaign for vaccination for polio. That's again, so competing priorities. So with this kind of situation, how we are able to use existing systems and labor is very, very critical. How we prioritize, what we prioritize, right? And then obviously the key challenge also what we see is the population's understanding and perception of risk of getting COVID-19 is particularly in Tanzania, when we said originally statement there's no COVID in the country, and then with some political changes, there were some new developments, and now we're releasing data and we have information, but the perceptions don't change so easily with the government change. It's not a quick switch we can turn off or on, and then people will start getting vaccinated. There are a lot of myths and beliefs in the community we need to tackle and address, particularly as we see declining COVID-19 cases, steady decline starting from January. So people think that, oh yeah, there's less cases, why I need to get vaccinated? Legitimate question, right? And then when you look at the resource allocation and how you use resources, then policymakers and decision makers sometimes say, oh, well, we don't have this issue as priority right now because there is a steady decline. But we know this can be very misleading because we've seen spikes of infection. We've seen in some countries there was a steady decline and then spike again. So we need to be prepared. We've seen what is happening in China again now. So I don't think we can relax and we can believe that there will be no COVID challenge or any other outbreak, because here we're talking about COVID-19, but what we eventually want to have is resilient systems to address other shocks and other potential outbreaks and pandemics as well, right? So we know that it's not the last one, and we know it's coming. It's not about is it coming or not, it's just when it will be, because when global health community was talking about possibility for pandemic outbreak, there were a lot of skeptics saying, oh, nothing is going to happen. But we've seen it's real, it's there. And it has enormous impact on the health systems.
And you make the point that COVID isn't going away. I'm case in point, I had it 2 weeks ago. And Lolly, there's one question, and I want I want to highlight to all of everyone out in the audience, I encourage you to please ask questions in the chat. We will have time to get to them, but as you're thinking of them along the way, please put them in the chat. But I have a follow-up question from Lali's, the comments you made. I'm just curious, Lali, what have you seen to be effective last mile strategies? What have been some of the effective strategies to kind of vaccinate or care for that kind of the last mile communities?
Again, I would say there's no cookie cut approach here. I think we need to understand what are the key obstacles and key barriers for reaching that last mile. And that requires a very tailored approach for every country, every community, every region. And some places it could be just the issue that they don't have adequate transportation. And if we figure out how we can engage the private sector or bada drivers to help us deliver supplies to facilities, that can address the issue. In some places it's more complex. So that's why I'm saying, I think the one key element we've seen is that usually those last mile challenges are not simple and require close collaboration between key stakeholders and require also engaging the key people in that particular locality. It will be a district authority or regional authority to be committed and to be willing to bring together all stakeholders and find out what is the issue and what everybody needs to do to tackle that issue. Therefore, there's multi-sectoral coordination mechanisms at the local level, which I may be supporting for NTDs and other disease, malaria and other diseases, proven to be very successful because they come up with very tailored solutions based on discussions and findings which are relevant to that particular district or region. I know I didn't give you the magic solution here, but I think that
it's very true that it is not cookie cutter. Have there been any strategies you've seen in your purview in Tanzania that have been successful, like a localized intervention?
I think in Tanzania, what was really showed the difference is when the government made a commitment to vaccination, and that when the government really engaged the regional teams and regional and district level authorities into the committing their resources and time and coordinating those efforts at the local level. I think that's what is made a big difference. We still have a long way to go though.
Sure.
We only, as I mentioned, only 6% of the total population is covered, but I think we see there's a steady increase in uptake of vaccination, and more needs to be done. Much more needs to be done, obviously.
Well, thank you, Lali. Belinda, this next question is for you. Lali brought up some great points, some of the challenges with COVID, inadequate storage of vaccines with supply chain, the complexity of last mile strategies, the lack of a healthcare workforce, no adequate surge capacity, and perceptions of risks around COVID. And making that last point, how the government changing its position in Tanzania was a really significant factor that actually helped turn the corner. So from your perspective, Belinda, can you share examples where where you've seen resilience in the healthcare system, where resilience has really been demonstrated through the pandemic?
Yes, absolutely. So at Lilly, we have this goal of reaching 30 million people in low income settings by 2030. And prior to 2019, we were doing a lot of individual projects on our own. And we realized that that's not going to get us where we need to be. And we started exploring what is out there. And one of the partnerships that we've entered into was actually with a number of other pharmaceutical companies, including Pfizer, Novartis, as well as the Bill and Melinda Gates Foundation, working with two NGOs, Last Mile Health and Living Goods, It's called the Health Worker Training Initiative and operates in various different countries here on the continent. And the goal was to train healthcare workers. So the one point that I want to make is, and I think it's come up before, is work with the systems that are in place. And this is what was being done here. The Health Worker Training Initiative was looking at, we already have these healthcare workers in place, focusing on things like family planning, pre-postnatal care, and they're already there, but they don't have everything they need. Okay, so the objective of this project that started in 2019 is really to give them the tools that they need to do the work and to serve communities, particularly the communities in rural areas that are far from hospitals and clinics. As soon as the project started, COVID started. And they had to pivot very, very quickly and include in the training, not only increasing the knowledge of the areas that they usually worked on, but also focusing on COVID and seeing how the healthcare workers can come into play and also help to spread the disease, to spread COVID, and at least not have a reduction in the level of service that they were offering. And they had to find innovative ways of doing that through training, to giving them digital tools that they needed, to making sure that they are compensated. Well, this doesn't usually happen with community healthcare workers. They usually get a stipend, but one of the areas is to make sure that they are compensated appropriately for the work that they're doing, that they have the correct training, that they have the correct tools, and this is what was done. They pivoted very quickly, and they were able to help to spread to reduce the spread of COVID, and at the same time still deliver the services that they needed to deliver. So it's just one area, but it highlights how working with what is there already, healthcare workers are in place. What do they need? The second thing is, if you are only one company trying to do this, you may not have all the resources that you need. So partnering with other organizations and then partnering with people that are on the ground, that know, that have the expertise. And obviously the community healthcare workers is one of the arms of the services offered by government. So working with that as well, working with the governments in the countries. And once again, just showing that it is partnerships. It's bringing in the private sector, bringing in the public sector, working with what is in place, making sure the necessary tools are there, and then building on those tools. You can show that in some places we can still achieve certain services, and how can we just continue to do that? How can we just continue to strengthen those things and use what we've learned in the pandemic?
Belinda, that was a great example of your proverb that you shared.
I need to get off this.
That very clearly, you go much further if you go together, and not trying to build something from scratch, but looking at what were the assets that already exist and expertise that already exists. So working through the infrastructure of the community health workers and just building the resiliency of that infrastructure, that's just a great example. Dr. Sifa, we're going to kind of shift a little bit. COVID has clearly disoriented and destabilized many aspects of daily life globally, but this had massive impacts on all aspects of normal life, but particularly on development strategies and methodologies in Africa. So I'd love for you to share, how has COVID-19 required us to rethink development? How will development work be different going forward from your perspective?
Thank you very much. First, let me say, as you know, the COVID-19 pandemic has created unprecedented disruption on global health programs and development activities in Africa. It has undone so many development gains across various sectors. Health and other development activities were significantly affected. For instance, Project Hope, my organization, will primarily focused on health programs here in Africa. maternal child health system strengthening, HIV/AIDS, TB are primarily our program areas of focus and interest. To share you some of the things that we've observed in our experience that regard. Africa accounts for 67% of people living with HIV. And the COVID-19 pandemic had significantly affected the way we've been providing different HIV services to our target population in many of the countries where we're operational. It affects the way we reach to different community service delivery outlets and primary healthcare facilities in the past, just before the pandemic, that were really providing high impact HIV/AIDS care and treatment services, HIV testing, linkage to laboratory services and things like that. That was significantly affected by the pandemic because the way we've been implementing programs didn't really take into account and in consideration pandemics and also some shocks and crises like the COVID-19 pandemic. It has significantly affected the way we operate and the way we function and provide services to our target population. By that, it significantly undone some of really glorious achievements, I would say, in the HIV epidemic control, for instance, tuberculosis control, and providing of maternal, newborn, and child health services in the region. So there is now an urgent need to examine how a potential pandemic like COVID-19 would really affect the way we design, implement, and monitor programs, development programs, and activities as we move forward. So we need to kind of like rethink and then redefine our development models and implementation approach by creating a project that's going to be resilient whenever there is a shock, be it in a form of a global health security threat like COVID-19 or the other natural or man-made kind of like crises. So in that regard, nowadays, I mean, moving forward, I would say the mainstream development approach and philosophy, which is oftentimes top-down and a little bit rigid and oriented towards narrowly defined health and socioeconomic goals. I think post-COVID-19, we need to have a development philosophy and model that's really radically transformative, egalitarian, and inclusive, and it should be participatory to ensure whatever development tools, approach that we are using would respond quickly and to any kind of health or other crises when they happen or they occur. I would like to give a couple of few examples we've learned and that we've done.
That'd be fantastic.
Yeah, when we've been managing our programs, we tend to integrate a crisis modifier into our existing development programs and activities. That way, we've managed to respond quite effectively and efficiently to COVID-19 related issues. I would name like one good example that we did. We have a USAID funded program here in Ethiopia where we've been providing maternal, newborn, and child health services in 4 remote regions of the country. Having a crisis modifier integrated into our development mechanism helped us a lot to quickly mobilize resources and respond to COVID-19 impacts. And we've managed to sustain and continue basic comprehensive emergency obstetric care services, newborn and child healthcare services because of the crisis modifier strategies that we managed to integrate into our program. We've been also noticing different development agencies trying to use co-creation models where instead of having request for application or proposal, which really comes out from the donor or funding agency, Rather, those agencies really try to engage government, host country government agencies, ministries, and development actors in the co-creation and co-design of the implementation program, which is also another good example. The other thing that I want to highlight is we've managed to design programs using innovative approach. Again, few examples. We have an HIV scan treatment program.
We'll let you do one example.
Where patients were regularly visiting health facilities and collecting their antiretroviral drugs. Before COVID-19, we shifted and changed that model into a community-based, more decentralized ARV distribution to people living with HIV, so that health facilities won't be really congested by HIV patients to collect drugs while they were handling a surge of COVID-19 cases and case management. We've also managed to provide virtual services to adolescent girls and young women, for instance, in Namibia through our DREAMS program, and orphan and vulnerable children were reached through different virtual means also in Zambia. Those are the kind of a little bit like creative and innovative development approach that we've used and learned from the pandemic.
Dr. Sifa, that was incredibly helpful. I really appreciate the examples. One theme that clearly came from your comments are, rather than kind of a top-down development approach, really a community-based development approach, that solutions are looking at, I mean, similar to what Belinda had shared, what are the assets and strengths within the community? How can those, can we build a program, project design around those assets? And rather than bringing in a top-down outside of approach that may or may not be contextual, may not work. And your two examples at the end were very helpful. We're going to stay focused on kind of a really specific area. We're going to go to you, Maria. Earlier, we talked about Africa, what has been a leader in modeling best practices in responding to the pandemic as a result of its already mature public health capability to respond to infectious diseases. But one thing that Maria brought up, and we had a pre-call to talk through what we would be talking about, and she talked about this idea around countries and pharmaceutical players could be taking a greater step towards the production of COVID vaccines in Africa and not relying on vaccines being produced from other countries and being shipped in. Maria, can you talk about what efforts are underway with countries and manufacturers to invest in vaccine manufacturing within the continent? What needs to happen from a policy perspective, from a practical perspective to really ensure that Africa will be producing its own vaccines in the future?
Okay, thank you very much, Michael. Let me use this opportunity to thank PQMD for inviting us. I work for United States Pharmacopoeia, and for over 200 years, we have been supporting global public health by ensuring that only quality assured medicines, medical products, including vaccines and biologics, are available for public health interventions globally. I would like to use this opportunity to also mention that one of the key players that play a very strong, have a very key role to play when you talk about pandemics and emergency is the regulator. The national medicine regulatory authorities, remember that most of these products we use as laymen, if you are a layman, you may not be able to discern the difference between a poor quality product and maybe a genuine or quality vaccine or medical product. So we all rely mostly on the national medicine regulatory authorities to assure the quality of these products that we use. So from the perspective of policy, the medicine regulatory authorities all globally and in Africa, I think I would like to really commend these regulators, especially in Africa, because before the pandemic, most of the regulatory agencies in Africa were only very few were quite strong. Most of them were on the average to weak capacity because, as you know, we have a lot of issues with availability of resources to drive regulatory systems in Africa. So, but it is noteworthy that during the pandemic, most of the regulatory agencies in Africa were up to task. They had the opportunity of reviewing the common technical documents, and we supported United States Pharmacopoeia. We also have a program that is running in several different low and medium income countries. We have several countries supported in Africa, Nigeria, Ghana, Senegal, Burkina Faso, Mali, Kenya, Mozambique, supported by the PQM program. We support to strengthen the regulatory and quality assurance systems in this country. And during the pandemic, they rose to the challenge of testing the lots of the vaccines that were shipped to the country, and also granting emergency authorization use for those vaccines in the country. So I think that's a very good thing to mention, because I didn't want to forget it, so I tried to mention it now, that the regulators are doing a great job, and they need the support of everyone that is on this call to ensure that they get to where they want to get to. So when we talk about policy, some countries have developed the required vaccine policy to drive local manufacturing of vaccine in the respective country. For instance, like Nigeria, last year, the national vaccine policy was developed and launched. And I know that several countries are also working on that. Ethiopia have a pharmaceutical roadmap, and that pharmaceutical roadmap also covers issues around vaccine manufacturing. So a strong policy, well-developed policy is required to create the enabling environment for local manufacturing of vaccines and biologics in Africa. Currently, we have a situation where barely less than 1% of the vaccine required for vaccination in Africa is produced in Africa. So that means that Africa rely heavily on importation of vaccines. Now, during this period of pandemic of the COVID-19, the African medicine regulatory framework was created. We also had the creation of the African vaccine vaccine regulatory framework was created. The African Vaccine Manufacturing Initiative was created. An African Infodemic Response Alliance was created. And then an African Vaccine Regulatory Forum that has developed a strategy and guidance for emergency preparedness to ensure that clinical trials are done seamlessly, was also developed. So you can see that the platforms, all the forums that were created have different mandates and different guidelines. These are some of the platforms that are available to ensure that vaccine manufacturing is taken to the level of at least 60% by 2040. Now, I want to also mention quickly that several countries are also investing and showing interest and at different level of investing and pushing local manufacturing of vaccines to different level, to advanced level. For instance, South Africa, they have done so much. They're already producing different one or two type of vaccine, of COVID-19 vaccine. Before now, that was not in place. But this COVID-19, I can see that it has triggered innovation and advancement, especially in the pharmaceutical industry. We have Senegal, we have Nigeria, Kenya, we have Morocco, Egypt, Tunisia, we have Algeria. Some have indicated interest even in the WHO plan to establish the hub and spoke RNA vaccine production hub in South Africa. Now is in South Africa. Several African countries have indicated interest to benefit from that technical support to start to manufacture vaccines locally. I also want to say that, so it means that the COVID-19 pandemic actually triggered an innovation, an initiative that will help to improve or provide the needed vaccine in terms of, for instance, malaria, which we know is preventable, but is killing millions of people, under 5, pregnant women in Africa. We know that there is a vaccine that has been developed now, and it's rolled out already. It means that with this new technological push for the African manufacturers, the regulator, the government, investors to invest more in vaccine, it means that with the emergence of any other future pandemic, at least Africa will be in a good position to look inward and see how to quickly replicate or engage in tech transfer to quickly produce some of the next needed vaccines that is required to address some of this pandemic. So thank you very much, Mike.
Maria, that was a phenomenal picture. So from what you shared, there's so many factors that are going into this future ability for Africa to be producing from 1% of its vaccines being produced in Africa to a goal of 60%. And you said the regulatory environment is completely shifted because of the pandemic. It's pushed this focus on developing clinical trials so that they can be done seamlessly, that there's now this vaccine manufacturing initiative. There's all these different players that the pandemic actually spurred innovation and collaboration, going back to Belinda's point that we go much further together, that is actually building the infrastructure to deal with current challenges such as malaria, as well as building infrastructure for future pandemics. That's a beautiful story of how Africa is not a victim. It's actually proactively building resiliency, building leadership, building capacity, and even building a model of public health infrastructure that the world can follow. And yeah, I just really appreciate that, your experience and your perspective on that. We're getting close to time. We're at 9:13. We have about 17 minutes left. I'm going to ask one question from the audience that came up in the chat, and then we're going to go to kind of a final round robin. So there were 3 great questions, but I'm going to choose one. It was mentioned that vaccine equity and access are generally stronger in urban areas compared to remote rural areas. Love to just hear, can you share, any one of you can answer this. How do issues of vaccine demand and vaccine hesitancy compare in urban versus rural areas? So we'll take that one question from the audience, and then I'll leave you with our final round robin question. Who would like to address that? How do issues of vaccine demand and hesitancy compare between urban and rural areas in Africa?
Just to clarify, Mike, are we talking about COVID-19 vaccination or overall vaccination?
Yeah,
because I can take a first stab, and then please, my colleagues will add. As one thing I can say that we know from routine vaccination, there is a huge discrepancy between urban and rural population as well, because rural populations have more limited access to health facilities and health services. We know that, particularly in sub-Saharan Africa, and there's some studies that demonstrated that. I don't know how we can evaluate that yet in COVID. It's too soon to say because we still, like as I told you, we're still starting to roll out vaccinations and stuff. And I haven't come across the study in sub-Saharan Africa that actually has evidence like how rural versus urban population in terms of demand and in terms of uptake of the vaccination and access, availability of vaccination. I don't think I've seen, maybe there is such kind of study, but I haven't seen it. I know that there's some publications for developed countries, like for US, there were some publications in US that there's some discrepancy there. But to be really honest, I don't want to speculate because I haven't seen any study that says, okay, this is what we see in terms of the COVID context. So I don't want to give my perceptions. I think we need to be on evidence-based here. Over to you.
Yeah, thank you, Lali. Well, we began our time with each of you sharing one key takeaway that you would like our audience to walk away with. And throughout our conversation, you clearly painted a picture of real challenge faced by the public health system, but also shared examples of strength and resiliency as leaders have developed creative and comprehensive ways to respond to the pandemic. And I feel like if there's a theme, I started with this Martin Luther King quote, but honestly, I think our theme is what Belinda shared with us, that if you want to go fast, you go alone, but if you want to go far, you go together. PQMD was created to be a network of working together, private and public sector, nonprofits working together to build resiliency and solutions. So I would love to hear from you as we're leaving. What is one key gap that you think the PQMD network, you have everyone here listening to you, what is one way that the PQMD network could partner together to address, to continue to build resiliency in the public health system in Africa? So we're going to start with you, Belinda.
I'm going to start sounding like a broken record, I think, but I think it's continue doing what you're doing now, bringing different stakeholders together, because one of the gaps that we still have is silo thinking. If I just think in the African context, so many African countries are trying to do the same thing, whereas if we just bring our resources together, if we just talk and if we just coordinate our approach, Africa can actually be a force to be reckoned with in any area. But like our egos get in the way. It's all about, no, we South African, no, we Nigerian, no, we Kenyan. No, we need to stop that thinking. We need to look at what the problems are. Our problems are too big and too complex to try and solve them on our own. We need to come together, different countries, private sector, public sector, all the stakeholders, and work together and start building on what's there and continue innovating and finding the solutions to the complex problems that we have. That's the only way I see. And I think we can. I absolutely think we can. And I think we've made good headway in this conversation and we should keep going.
Thank you, Belinda. Yeah, very much your theme of together is how we will solve these problems and challenges. Maria, let's hear from you. How can PQMD network support to continue to build resiliency in Africa?
Okay, thank you very much. I will say that PQMD is doing a great job. It's a coalition of different organizations, both private, different non-governmental organizations. So we already, just like Belinda said, it's an effort in the right direction. I would like to say that one of the gaps that I will say that we should work more on is ensuring we capacitate, we correct the regulatory inadequacy. If you compare Africa with advanced countries, there is a huge difference in terms of regulatory system, in terms of quality assurance system, even the manufacturing landscape. So more investments to bridge the gap of capacity to manufacture, capacity of the regulatory system. Also, I would like to say that we need more political push to get the political players to commit to investing more in the system. Thank you.
Thank you, Maria. So from Belinda, keep working together. Maria, really work to build the capacity of the regulatory system through advocacy. Dr. Sifa, what advice can you give to the PQMD network on how we can support in building resiliency in that public health system in Africa?
Yeah, thank you. I think to me, we have different vertical programmatic initiatives focusing on particular programs and disease entities, which is really good. And we've seen quite marvelous and impressive results on those vertical disease-specific programs. But in general, programs should really kind of like move towards a holistic and system approach to strengthen the healthcare system so that we're not really addressing a particular disease entity, rather we're building and strengthening the healthcare system in Africa, which eventually creates a resilient healthcare system in the region.
Thank you, Dr. Sifa. Dr. Lally, let's hear from you.
I think I actually believe that everything that was mentioned is very important. One thing which I want to say is that I think that PQMD is a great platform for sharing innovations between the private, public sector, faith-based sector. And I think if we work together, we can help those innovations which are developing in private sector, because private sector very often has more resources than nonprofit organizations, faith-based organizations. We can help bring those innovations to scale. I can give you an example for COVID-19 response. We worked in collaboration with Africa Christian Health Association's platform, which covers 5,000 health facilities across 32 countries. If we have some interesting innovative things that are developed by the private sector, can be, and they're looking for scale up, we're there, we can help provide that linkage, and we can help facilitate everything that is needed at the country level across multiple stakeholders. That's what we do. I would say we're catalyzers, we're facilitators. We don't want to be viewed as service delivery outlets. That's not what our job as international organizations and development partners are. We are there to catalyze, we're there to support, build the capacity, to keep the sustainability, but I believe in addressing many public health issues. Innovations are key. And we're there to help bring those innovations and catalyze those processes at the ground level. Over to you, Mike.
Yeah, thank you, Dr. Lally. I really agreed with your statement that private has more resources than public. That I think we all agree with that. But I really appreciated this idea that private can really help bring solutions to scale, but in that we as NGOs, we're not there to just be service oriented. We're really about building capacity. And that really is in line with kind of what you shared, Dr. Sifa, that holistic, bottoms-up, community-based program design is much more effective than top-down program design. Last but not least, we're going to end with you, Abby. What words of wisdom do you have to the PQMD network as to how we can support building resiliency in the public health system in Africa?
A lot has already been said. Like Lily said, Belinda said, it's very important to harness the strengths we identified across Africa in the course of this pandemic, to harness the innovation. And PQMD can work together with various parties, stakeholders, NGOs, private partners, to enhance this and bring it up to scale. Also to check what are those weaknesses that are in the system, like the regulatory that Maria mentioned, and other weaknesses, and how do we tackle them? And then importantly, while the political will is still there, this is the right time to kind of work with the leaders in the various government organizations and socialize this idea while it's still hot, get it going before we lose momentum. Thank you.
Well, I don't know about you, but I have a lot of hope and excitement after hearing from our panelists, these leaders that are leading these incredible movements in their continent. And if you want to go fast, go alone. If you want to go far, go together. I think that is clearly the theme, and that's the spirit of why PQMD exists. We exist to come together to build grassroots solutions that help build the capacity of public health around the world. So we're just really grateful to all of you panelists. Your expertise was inspiring and informative. I'm going to pass it to you, Julie, to bring us home.
Thank you. Well, that was an incredible session. Lots of seasoned insights and really great takeaways. So just on behalf of PQMD, I want to thank you, Mike and Stephen. I want to thank the audience and how fantastic it was to share this session together, and especially to our esteemed panelists. We are so grateful for the time and the perspectives that you shared today, and also for the work that you do every day. And it's exciting to see the level of conversation and potential collaboration that happens at a regional level in Africa. And so we hope this conversation continues. We're going to post the recording of the session on the PQMD community of practice afterwards. And as I mentioned in the opening, we have treasured this series over the past few weeks, and that we hope that PQMD member organizations and companies feel more connected at all levels of our partnership around the globe. We are super, super excited though for the return of PQMD's in-person Global Health Policy Forum that will be centered on timely issues in global health next year. And so mark your calendars, literally a year from now, we're going to be in Paris, in France, hosted by Tulip, and you are all welcome to join these sessions from April 24th to April 27th, 2023. And so just to close, thank you again for joining us all today. This is officially closing the 2022 Global Health Policy Forum series, and I wish you all a wonderful week. Thank you, everyone.
Thank you.
Thank you so much for the opportunity.
Thank you for the opportunity too.
Thank you. Bye.
Bye-bye.
Bye.